Recording. So whenever you're ready.
Okay. Hey guys, how's it going? It's Ray Lynch. I'm a physical therapist, and this is the third recording with Aaron and myself. So Aaron, I'll let you kind of introduce yourself. And guys, the topics that we're covering today include warm-up, cool-down, and core stabilization. So actually, today's topics, they're actually things that Aaron and I may actually have some disagreements on, which I think is good because we're both in two different professions. There's some crossover there with him being a strength and conditioning coach and me being a physical therapist. There are some crossovers, but there's also things that we're not going to completely agree upon. And I wanted to bring those to light because I think a lot of times what you hear out there is everybody kind of a bunch of yes men when it comes to these topics, core stabilization, and it's really kind of popular out there in the physical therapy world as well. So just wanted to talk about it. Aaron, I'll let you introduce yourself, and then we'll kind of move on to talking about core stabilization first.
Yeah, so Aaron Fick, strength and conditioning specialist by trade, been in the realm for about 10 years now. And just to piggyback off that again, I think we're starting to hone in our conversations, and for sake of interest, I think if we continually keep the controversial topics coming, that'll be what people are truly interested in. Like you said, with a bunch of yes men is just boring conversation, but it's also, most importantly, when we bring up topics that certain circles disagree upon, and we get those circles to come together, we will continue to depolarize it rather than polarize it. So if we stay in our bubbles and we talk about what we agree upon, all we're doing is polarizing more. Whereas it's important that we have to come out of our bubbles, talk to different bubbles to keep polarization from happening, or else what we're trying to do ultimately isn't going to be successful. And we need to always, keep in mind that the majority of us out there are trying to do the right thing. Obviously there's the few that are out for the money, and there's the few that are extremely just ignorant. But obviously that's not you or I. So conversations like this are going to be juicy. They're going to be much more fun, and it's going to keep dialogue open and keep us on the right track together. So
absolutely. Man, let's so we're going to start, guys, with core stabilization. So Aaron, I'll kind of let you take the floor. Let's just talk about things we don't like from that terminology. I've got a couple things there. I know you do. What are some of the things that you see out there, not only in the fitness world, but maybe even if you've even looked over into the physical therapy world, whatever, man, what kind of things are you seeing that you don't necessarily agree with from a core stabilization standpoint?
Sure. Yeah, let's do that. Let's talk about what we don't like, and then
we'll probably find something here.
Yeah. Let me throw out what I don't like. I'll let you throw out what you don't like.
Sure.
And then I think I'll present my literature, you present your literature, and then I'll present my experience, you present your experience. I think that'll be a good trend for it.
Perfect.
So yeah, with what I don't like with core stabilization, it's a hot topic. It's a buzzword. It's just as buzzy as functional, and all those good buzzwords out there. So right off the bat, core stabilization is a buzzword. There's a lot of vibe to it. There's a lot of hyper focus on it. Mm-hmm. The term itself and what it is, I think, is good when it's left at what it is. However, because of the over obsession with it, which is what I see, it's gotten too much light, it's gotten too much focus, and that's where a lot of my dislike comes from. The core is important, and it's not overly important. It's not necessarily a focal point. When we're talking about the core, we're talking about the abdominal structures, the low back, the erectors, a little bit of leg musculature, a little bit of upper body musculature. Essentially, the core, what's keeping us together. Very important, but not any more important than something specific with the arms, something specific with the back, something specific with the legs. I don't see it as extremely important. I don't see it as a number one priority. I see it for what it is.
Yeah.
And a lot of my dislikes just come from again, going back to the ethical issues, right? Entire businesses are sold on core stabilization.
Absolutely.
Entire workouts are made around core core training, and a lot of the intellectual talk and $5 words is around the core. And lastly, what I really don't like about the core is trying to make it a scapegoat for everything. Oh, hey, this hurts. Well, your core. Oh, you failed at this lift. Your core. Oh, your poor performance is low. It's because of your core. Yeah. There's just way too much emphasis on the core, and I want to make sure that it doesn't get that emphasis from me, because one, we will demonize the core. Right, we can have the pendulum swing the other way and say, "Oh, let's forget the core at all," or we can have it stay where it's at right now, which is just an over obsession. And anytime we over obsess about something, we get distracted from other important standpoints. So my frustration comes from just too much focus on it.
Too much,
It's the celebrity exercise, you know.
Yeah. No, absolutely. And so I'll kind of piggyback off of you. So I think we share a little bit of the discontent with the term automatically. For me, what I see in the clinic when someone comes in and they say, well, your core's unstable, we need to stabilize it, I hate it. Because we had a talk a couple weeks ago about, nocebo or placebo when you open your mouth. There's no neutral. And I think, to me, when you're telling a patient who may already have anxiety and fear avoidance, depression, whatever, you're basically telling them, hey, your back, it's unstable. Like, it's moving way too much. We've got to stabilize it. Like, that only is going to ramp up fear, ramp up anxiety in that type of individual. And I think we do overemphasize it. Absolutely. I think on both ends, right? So from a strength conditioning side, from an athletic trainer side, and from a physical therapy side, I think we do a poor job in general of screening when it's appropriate, right? So doing certain interventions in physical therapy is appropriate if you're making sure that they fit that, but making everyone fit into core stabilization because that's your bias or that's kind of the camp that you come from, I think is absolutely swung the pendulum in that direction, where in our field, there's a ton of literature focusing on it, which is fine, right? But then you've got disagreement on, well, is it just TA activation? Like, is that what we need? Is it just TA, or do we need IAP or intra-abdominal pressure? Like, what's important, And I think that we overemphasize it in our field as well. People are hearing things like your core is unstable. I don't care for that. I think that's just going to induce fear. People are not going to want to move. And even if we have good intentions and we take that biomechanical approach and say, oh, well, this is moving a little bit too much, and so your psoas or whatever is grabbing, we basically affected the patient and caused more fear. So that's one thing I don't like, is just the term. Can we just call it motor control? Can we call it, something else? But I think core stabilization, while I think initially had good intentions, I think the verbiage sometimes can actually be a little bit misleading. Not necessarily misleading, but it can actually invoke fear, invoke anxiety in certain individuals. So I think we have to do a better job screening that. The other thing that I don't necessarily care for, like you said, is just the overemphasis. So in training programs, right? So rather than going over and lifting doing some deadlifts or doing something else that really gets everything to work together, it's, hey, let's do this functional core exercise. So what I'm going to have you do is bend over backwards over a Bosu ball, which is just freaking terrible. They go over backwards over a Bosu ball, and then they come up and then they just kind of throw a medicine ball to their trainer. To me, and we may disagree on this one, but to me, I'm just like, really, like, it's not working as a functional unit. You're basically just training it in one direction. And I think the core is better served. And in the literature, it even shows like the flexion-based exercises are causing more injury. But I think we're better served once we get out of the injury phase, moving on to lifting. Right? So doing deadlifts, doing some squats, doing something that makes the core manage the extremities and provide a stable base, rather than getting obsessed with isolating it after they get to that point. That's my 2 cents, is that we do a little bit too much to isolate it as well. When in all reality, once they're past a certain phase on the spectrum, they need to go ahead and just basically lift a little bit and they'll be okay. Right. Did you have something to say to that?
Yeah. So, just kind of continuing on with the conversation, the core, it's just it is what it is. It keeps the body together, and when we move properly and we exercise properly and we do these multifunctional, multifaceted, multi-joint movements, it's going to do its job, right? This overemphasis of thinking like, hey, I need to isolate what you're doing here, and this is going to translate to this complex, very quick reactive movement. It's not true, right? You're going to use your core how you need to when you do the exercise correctly, right? That's the definition of doing it correctly. So I think where our disagreement might start is I really don't. I don't focus on the core. The core is a part of the movement, right? When I'm programming and things like that, people are like, well, where's the core work? Where it's like, well, it's in every other movement. So when talking about the core, what we're talking about is stabilization, right? Making sure that the body is in the position it needs to maintain and stabilize while performing exercise or performing daily movement or performing whatever you're doing, right? That's core stabilization, just keeping your body in check. And that happens naturally. It really does. When you surprise, my perfect example is when you surprise somebody with something, or you have them lift something with minimal cueing. What happens? They just naturally brace themselves. They're tensing up, they brace, they get ready for it. It's a natural response. It's impossible to complete a squat or a deadlift if your core's not braced, right? It's just part of the movement. It's like saying, the hamstrings aren't working during the deadlift. That it's just not true. The only way the movement could have been completed is by the stabilization, the contraction, and the movement of that compound lift.
Sure.
When it comes to the literature, there's a lot of hyper focus and talk about pain and core. And the literature that I've been seeing, I think the core gets credit where credit isn't due. And so a lot of exercises and evidence is being, I don't want to say mistranslated, but just giving credit where it shouldn't be due. People with low back pain, they do some core exercises. There's a reduction in pain, and they give it credit to the core, where I give it credit to they just started moving, they just started exercising, just started getting focused. And I say that I take that route because there's a little bit of support behind it. There's a meta-analysis that I want to quote pretty recently, 2015, I believe it was done on, and they actually try to compare this low back pain with core exercises or general exercise. Yeah. And what they saw was the outcomes were both beneficial. And again, this gives credit to core exercise, but we don't want to overemphasize it. There was a relief in back pain or an improvement in back pain because they exercised, not specifically core exercising, although core exercising did improvement. There was a systematic review, if I'm pulling them off the top of my head, systematic review on systematic review on focusing specifically with core exercises, isolated core exercises, and they used EMG activity. So we got to take that for what it's worth. But when we compare EMG to EMG, I think that's appropriate. That's okay. Keeps the playing field even. But they compared it to isolated core exercises and a focus on compound movements. And this systematic review was done in a strength and conditioning basis. And essentially what they saw was, again, no outstanding improvement from isolated core movements. There was no more engagement than there was from compound lifting. And so essentially the researchers, I agreed with their conclusion, the fact that, look, there's no difference except for the fact that one's isolated and one's focusing on the next step. So why don't we just cut out the middleman, i.e. core training, and let's just get to training. Let's just start moving these heavy lifts. Let's just start progressing in movements. Let's just let the core do what it's going to do. And by nature, it's improving. It's still being stressed appropriately. It's still being used how it needs to be. And that falls more in line in my agreeance, because it's treating the core how it should be treated, right? The body is fluid. We're constantly moving. How do you isolate a movement that's constantly involved in every single exercise, right? We can put everything else in a box. There's upper body workouts, there's lower body workouts, but then there's the core, right? That the core is just everything. So I guess that's where, it gets its hyper focus in, but at the same time, because it's involved in everything, right? It's getting trained. Do your movements right. The comparisons in the literature, and I try to stay away from like individual studies,
Sure,
just
absolutely.
because of biases, right? I try to stay with the
Yeah.
systematic reviews, the lit reviews, the meta-analyses.
Yep.
But even just recently, just trying to brush up on some stuff right before we started talking, was an individual review that essentially stated there was what I would say bias towards core training, but even in this individual review, the ultimate goal was, hey, we're going to start with isolated core exercises, but the goal is still to get to full movement. I don't think they gave credit to compound lifting and strength and conditioning, but they gave credit to multifaceted, broad domain, just movement, just getting back to daily living and understanding that the core, just walking or moving upstairs, is it stabilizing? Is it propulsive? Is it rotational? It's all three simultaneously nonstop, right? It's just bracing and moving and doing what we need to do constantly, with like I said, a multifaceted approach. So I don't have a reason to focus on the core, just because everything is the core, right? We're just going to train. We're just going to continue to work, and I'm not convinced that there's any sort of special benefits to isolating the core for somebody post rehab, which is the only area that I can speak in.
Sure. Well, and what I would say, man, is I'll give a couple case examples as we kind of get into it, but there's some things I agree with. Like, right, once I get to you, man, I mean, the reality is I think it's perfectly fine to not spend a lot of time focusing on it, right? If they're doing it with, appropriate load management, I think is actually probably more important than isolating the core, right? But I think appropriate load management, progression in an appropriate manner, and at least having relatively good form with the movement, I think is more important and will get the abs and the core engaged more so than just going and doing some crunches and sit-ups, which quite frankly, I hate. I mean, I hate both of those. Do we agree on that one, or do we? I don't
sure.
know.
Yeah, we'll probably disagree there, because the one time I'm going to isolate the core or even have a remote care for the core in and of itself is with any isolated movement, and that's for localized hypertrophy. You want to get a little bit more hypertrophy going in the abdominals. Cool. We're going to do some crunches. We're going to do some sit-ups. I'm not opposed to sit-ups. I'm not opposed to crunches.
Yeah.
It's minimalistic in terms of it's not going to wear you down after your heavy lifts. I'm not worried about too much fatigue management. Essentially, from a programming standpoint, when I put in core work, because of my view of it and because of the exercises we do, it's not even counted into fatigue management. Like I'm not like, oh, we need to back off your deadlifts tomorrow because you did some sit-ups.
Yeah.
It's not even an issue with me.
And I hear you. Yeah. When you're talking about, well, I do it with the purpose of hypertrophy, right? If you want some hypertrophy, yeah, go ahead and isolate it, right? I get it. And, in our field, like when we're talking about people with pain, so we'll bring it to the rehab setting, people doing crunches and things like that, they're not any of those flexion-based movements. A lot of times what they're seeing is higher incidence of adverse effects or adverse events, being whether it's joint pain, whether it's low back pain, whatever it may be. But that's kind of what they're showing with some of those things. But again, some of them say it's not a problem. Some of them say they do. I think for me, once they get out of there, I mean, it's never a part of rehab for me. I mean, those two are never there. So, I mean, I get your point from the hypertrophy later, but I know for me as a physical therapist, it's like, heck no, I'm not focusing on that. What I think will, so you mentioned a point, you said like cut out the middleman and we'll kind of move on. Basically in that study, right? Mm-hmm. Now, for me, I come from a little bit of a different background, I think. So just to me, like going and doing a plank or doing some side bridges or something like that, while those are typically the ones that they focus on in the literature, or typically your planks, your side planks, And then I can't remember the other one they typically do. They'll even do some like low back extensions, right? So, and so they'll do a little bit of that, and then they'll base their research off of that. So I think we as a profession in physical therapy have a poor arsenal or poor understanding, or I hate to use the toolbox expression because I hate it, but like I think we don't have enough in that regard. There's someone, Claire Franks out of California, does a thing called movement links, and they really focus more on IAP, so intra-abdominal pressure. Mm-hmm. And I think when it comes to core stabilization, I think that's appropriate to hit a little bit earlier, because what we see from a physical therapy standpoint is, are you familiar with the term like extension compression stabilization syndrome? So with the extension compression stabilization syndrome, with those individuals who are having low back pain and fit into that criteria, so we have like clinical prediction rules, right? So, hey, if they're less than 40 and they have a straight leg raise greater than 91 degrees or greater than 90 degrees, and if they have aberrant movement, right? So when you take them through the exam, if they have aberrant movement, and then the other one, I'll have to remember, it's a prone instability test. So basically you put them over a table, you go to the painful segment, and then you have them raise their legs to get basically the erector spinae and everything engaged, and you push on it again. If it decreases the pain, that's positive. And so those are some of it's a clinical prediction rule that we'll use, and we may do it with them. Yeah, I don't do it really with everybody. Jesus, you hit it, yeah. So, he just kind of out of nowhere. There was a girl, though, that kind of changed my mind on this. So she was in the military. She was a gunner, so she had to have a ton of freaking armor on, like all the time when she was doing it. And her job was really like very labor intensive. And she was already doing a bunch of lifts. Like she was strong, man. I mean, it was deadlifting, she was squatting, thighs were really thick, form looked pretty good. I mean, we were like, man, what's going on? So we watched her go through, and she kind of fit into this classification. Now, she had been getting injections in her back for pain management every 3 months for like 4 years, which was just insane. So some corticosteroids, they hadn't tried physical therapy. And so she comes in, and taking in consideration some of the components of the core, so the diaphragm, pelvic floor, the external, the obliques, basically multifidi, and everything else around it, right? We were like, well, how do we get her back? She was in severe low back pain. We were like, how do we get it to just stop grabbing? Because her erector spinae were on all the time.
So let me ask a critical question right now.
Yes.
So during this whole time you're trying to figure this out, what changed with her current training routine? Was anything adjusted for? Was anything on the side of her training? Was she still training heavy deads? Like, was there any management on that side?
No,
she's still doing this, and we're just going to try and
do something else? No, so she was still exercising, but not to the same degree, which was one of her main goals. Was, look, I love to exercise. I can't do my deadlifts at the same load that I used to. I can't do my squats at the same load that I used to. And she had basically cut all of that out prior to physical therapy. So she wasn't doing any kind of concurrent training with us and then still lifting. She basically was like, I'm not going to do anything. Every time I try and do anything right now, my back is seizing up, and which was crazy. So I had her doing basically some just breathing, diaphragmatic breathing. Just get the diaphragm engaged, try and lessen the pain, get the erector spinae to come down. And dude, I mean, I'm telling you, within 5 minutes, whole back was seized up. She couldn't hardly move. She was in a ton of pain. And so we basically gave her like a belt, which gave her a belt to just give the body some sense of stability or some sense of basically structure to that. And erector spinae calmed down. She was able to drive home and not have any issues. So as we progressed that, there was some pelvic floor work, like just basically light stuff, trying to tap into the nervous system, with a couple other things that Tim, is actually my mentor, was doing, and I was more observing. And finally, after like 3-4 weeks, she was good to go back. She was able to go out, was on deployment, basically was out there carrying around all the weight that she needed to, doing everything that she needed to, no pain. And then she was able to basically continue with all her exercises, and we heard from her maybe a couple weeks later she was fine. So I think in that case, it was someone that I would say she probably needed a little bit. Now, what were we doing, I think, is a better question. It was really more the focus on, IAP. We weren't doing like, well, let's do some posterior pelvic tilts and get your TA involved or anything like that. It was just, let's focus on IAP and getting just light IAP, or basically getting consistent IAP with extremity movement. So whether it was lower extremity or upper extremity, but being able to connect the two in that way. And she responded really well to that. Does everyone need to have that? No, absolutely not. And I think that goes back to the point of we overemphasize it and we give it to everybody. And I think that's where it needs to be, the certain select population. The pendulum's way over here. So for me, there's a couple people that I would use it for. It's similar to like what we have lumbar traction. I hate it. I don't think it should be used really hardly at all. But there are special circumstances that it can be used. I don't use it, but it's one of those things that the application of core stabilization training to everything, I think, is irresponsible. You were about to say something, so I'll let you say it, and then I'll.
Yeah. So we're another critical question to that would be, and that's what it kind of sucks, because then we don't know now because it's all in the past. But
yeah,
usually when I hear situations like this, and it goes both ways. Because she stopped training, like we just lost an entire variable there. So
yeah.
so now my critical question would be, what do we give credit to? Do we give credit to load management? She just backed off and had a reset, and then now she's queuing up and getting coached up, and she's going back with a proper brace and using a potentially a lifting belt now, or whatever the case may be. Like, did she just need that? Like, where does the credit go? Does the credit go to core stabilization, or does it go to the fact that there was a reset button pressed with her training and she went back to training and now she's a little bit more methodical with it? I wonder, and that's what can be frustrating sometimes with
Sure.
even trying to get studies, because you don't know who to give credit to sometimes when it becomes multifaceted like that. So and I bring that up because a lot of the times when I'm dealing with my clients, the closest I'll come to pain management while still staying within my scope is when those nags come up. We'll be in a training block and a nag will come up, right, low back, something like that, and we'll adjust loading, right? We'll
Sure.
stop. We'll go there and we'll approach it from a load management standpoint. Usually, what happens when these nags and these things that creep up into training, right? There's no traumatic experience. It just, one day they're like, this is starting to nag on me.
Yeah.
All that's telling me is that there's a program adjustment needed. Now, granted, boots on ground, I'm not there for every single experience, but when I hear stories like that you bring up, it always makes me just say, like, dang, like, why'd they stop training? Like, what? Like, from a scientific standpoint, I wanted everything to remain the same so that
absolutely.
I was like, no, keep training. I know you're in pain, but for my selfish reasons, I want to keep all aspects even so that I know what we can deduct from this. But anyways, that would be my question.
Yeah, I mean, so I'll give you another example, but in her particular case, it had been several months that she hadn't been doing anything, which, do I think the combination of things after she got into it? Absolutely. But in her case, it had been several months that she had stopped, basically because she was at a location where they were like, you can't work, you've got this note, you've got this, like, you really shouldn't be doing a whole lot of weightlifting like you normally do either. You need to rest. And so she was off for several months. So she was driving from Dahlonega to Atlanta to come see us. I mean, the girl was pretty desperate. And I don't know how. I think she heard of us through a neurosurgeon who referred over. But in her case, it had been before. But there was a guy that came in, I'd say probably 2 months ago to me in the clinic. And he had low back pain. And I looked at him. I watched his form. I looked at everything. I said, buddy, how are you managing your low before? Well, I wasn't. I was just kind of going in. I lift heavy, and once I got to lifting deadlifts at 355, it was this, and my doc said that my back has yada, 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 and the MRI says this. I was like, man, forget all of that. You didn't manage your load, right? I was like, there's no need. Like, I did some testing, some testing to see, okay, well, how does he manage from a core standpoint? How does he manage from a dynamic standpoint? I was like, he does fine. He just manages load poorly. right?
Yeah.
And so in his case, it absolutely was that. And I actually told him, I was like, look, man, once we're done, once we go through everything, I want you to give Aaron a call because I think he'd be able to help you better with the coaching. I said, I can get you over there and manage symptoms while you start on those things, and manage the other impairments. So like one of his hamstrings, when we do a 90-90 test, just to look at basically, are they even? One was like 40 degrees off from a flexibility standpoint. So restored everything from a foundational standpoint. And then I was like, dude, you just need to lift. You're fine. So that's a different example. But from a core stabilization, I'll throw out some of the research. And then I do want to agree with one of your points that you made earlier, because I would totally agree with it. So some of these things that they're looking at, it mainly looks at low back pain, right? So from a core stabilization, that's what they do. I don't agree with all the exercises they even use. I think we would probably get better research with different forms of exercise, but they've stuck with things that they can measure objectively.
Right, sure.
And tests that they can measure objectively. Like there's like a flexion test that they do to measure core stabilization or whatever. So, but I think, like some of them, like, so this is the this is funny, the Journal of Back Rehabilitation.
They got their own journal now. That's how popular it is.
Yeah, that's very specific. This is 2013 systematic review, and what they looked at is that from these core stabilization exercise, those being the side bridges, planks, and everything else, were better than the traditional exercises. The only problem is they didn't highlight what the traditional exercises were. And that's a problem to me, because just to throw it out there and paint it with a wide brush and say, well, it's better than exercises or better than movement, I think is a poor thing to do on their part. So if you just stick with the abstract, that's all it says. And even if you go into it, it didn't specify what the exercises were. So take that with a grain of salt, right? But it decreased pain, decreased disability, and chronic low back pain in the short term. Over the long term, there were no differences really found at like a year after, right? But in the short term,
I think I read that exact paper you're talking about. That
Really?
there was a short term improvement, but then when it came to long term, there was no difference. So with that, my critical question would be: it's funny you bring that exact test up. I just read that one. When I see those comparisons, then I wonder again, where is credit due? If in the long run it just kind of went away, well then, hey, they were just moving, they just kind of healed up, perhaps. There's a lot of variables there now. Now, is there some temporary relief or something that happened? Like, we do have to acknowledge the short term, but I always find that interesting. The short term versus long term one. That was my first critical question. Was, well, on the long term, then again, my reoccurring theme with these
is where's credit?
Lit reviews is, where is credit due, right? Yeah. That's always my initial question, where I try to be critical.
Well, and I think, some of the researchers sometimes, and if you go look up kind of what they do in their previous research, they there was actually one I gotta tell you about, because it's really funny. I think it was in warm up and cool down when we get to it, where it basically said there's no statistically significant difference, and then in the conclusion it said there's actually a difference and you should do this. And I was like, it actually may have been core stabilization. Let me see if it was, man, because that cracked me up.
Some bias going on there, sure.
I was like, come on, man. They didn't want to say that. They didn't want to completely just neglect it.
Sure.
But there was a Journal of Athletic Training, 2017. It said basically, I think this is actually the one, for short-term relief and things like that. To me, from a short-term standpoint, I'm completely okay with that. I mean, if it's like 2 days, is that really beneficial? Typically, these short-term follow-ups are a month, 3 months, 6 months. So a month or 3 months, if they can get out and do what they love to do, and then maybe start a program, I'm all for it, man. So I think that's where there could be some benefit. Again, in the short term, to let them do what they want to do, absolutely. But does it mean that that's the only thing that you should do over the course of a year? No. And I think that's the other thing too, is that when we compare some of these things, it's just core stabilization. And I think us as, or at least me from a physical therapy standpoint, is like, that's never the only thing that I do. You know what I mean? Right. It's like, that's never the only thing that I do, because just throwing someone in a box and treating them with just core stabilization activities is not going to be near as beneficial as that, integrating other movements and exercise and a combination of aerobic and strengthening and everything else, right? Even for management of chronic low back pain. When we talk about chronic low back pain, what they don't say is in our clinical practice guidelines, they review thousands upon thousands of research, and basically a team gets together and compiles it, whether it's systematic reviews or whatever, meta-analysis. Right. And what they actually say for chronic low back pain, which was brought up in this study, is that aerobic is actually one of the biggest things that you need to be doing. Aerobic, and also basically telling them, hey, as long as you have someone, watching your movement, make sure you got good form and good low management, get out there, So it doesn't, even though this Journal of Athletic Training in 2017, I think it may have been, I can't remember the type of study, I should have wrote that down. Even though it says, hey, it's better than just exercise, when we really look at the literature as a whole, it's not the first step for low back pain. I think They really, in my case, they really have to fit something very specific. And I think where we go wrong from a physical therapy standpoint is applying the same thing to everybody. Have you heard the McKinsey approach?
Yes.
So the McKinsey approach, when used in those individuals, can be relatively successful. If you look at our monographs, which is what I had to study for the OCS, it says it's not really effective. But you see people, and I see it in the clinic all the time, in their exam, they'll have them go into extension and flexion, and they're obviously not someone that's suffering from a disc pathology, and then they just give it to them anyways because that's all they know. Yeah. And I think that's where we've gone wrong, is that we just stick to what we know rather than getting outside of our comfort zone. And sometimes good intentions, but wrong application to our populations.
The first thing I do is I always got to go over the obvious with my clients. They're like, oh man, my back's sore today. I'm like, oh, well, what'd you do? It's like, I did yard work yesterday. I'm like, oh, okay, whatever, and I'll blow it off, and I'll let them know that I blow it off, right? I want to make sure that like they understand, like, well, that makes sense, right?
Yeah,
it's okay sometimes to have some low back discomfort, and other times. Especially with new clients, they'll come in like, yeah, I've got some low back pain. I was wondering if we could focus on that. And my first question would be like, well, what do you do all day? It's like, oh, well, I sit all day. It's like, oh, okay. Well, do you get up? They're like, no, not really. And then I was like, okay, well, do you do anything active? No, not really. It's like, well, I mean, we're not going to worry about it then, because you're going to be surprised what happens when you just get up and move.
Exactly. No, exactly. And I think that's well within the scope too, right? So they've got some low back pain, but they're sitting all day, and you're like, well, I just want to get you exercising, and let's just start here. Start with the foundational lifts and with a foundational program and manage your load. And usually half the time they're fine. And I think that's kind of where we're shifting from a physical therapy standpoint is, like you said earlier, is it that they're actually doing the stabilization exercises, or is it just because they're moving? And I think in a lot of populations, it's just because they're moving. I mean, I think just getting them over the hump and saying, like you said, brushing it off to some degree in certain populations and saying, look, not a big deal. Like, let's start lifting. I would say in special populations, and we may, I don't know. So women postpartum, obviously post-surgical, microdiscectomies, fusions, things like that. There are special populations that I would use specific IAP training and regulation and trying to get it from there. But I think in general, man, I think we would probably agree that people overemphasize core stabilization activities, and they basically should just get moving. And once they get moving, they'll be all right. And I 100% agree with that. Again, special populations, if anybody's listening from a physical therapy standpoint, postpartum women, whether that's with pelvic floor dysfunction or whatever, I 100% think that they need to have some kind of program. If you get the chance, there's a girl, Hannah Bauer, on Instagram. She recently had a baby. She's a fitness professional, and she did a little bit right after she had her baby when it was good to go. I think she, I don't know if she had C-section or not, but when she was able to start retraining, she was making sure that she had good IAP with the exercises. And then once she got in it, man, she's doing normal routine. So postpartum, post-op, I would say I still kind of would stay on the, they need something specific at first, but there's no reason to, as I've heard neurosurgeons say, never let them lift again or treat them in a bubble. Like you should still move them on to the next phase and get them to somebody like you, as long as there's somebody in your area we trust. Like, I wish you were here, but you're not.
Yeah. Well, I don't ever like to leave a conversation on a negative note, and I don't want to be the one that's hating on the core stabilization, even though I'm adamant about it. So I've got to give credit in one area for it. The one time that I will focus on the core stabilization is is for a coaching cue, right? I'm not viewing this as anything special, but simply teaching somebody to brace, right?
Yeah.
And even a brand new lifter, just to prove the point, I'll go grab a nice 4-inch, 13 millimeter leather rawhide lifting belt and strap it on them and have them practice bracing against that belt and be like, this feeling that you have, this contraction that you have, this is what you're going to feel by nature when we get you to heavy loads. Because again, somebody that's brand new to lifting, the things that we take for granted that we don't even think on are just totally mind-blowing for a new trainee. Like what a heavy load is subjectively for them, what they're feeling in their core. I can't tell you how many times it's funny. The first client that comes to mind was actually fused lumbar L3S1, and no core stabilization, so you can hate on me there, but
it's immediately post-op, like within the first, I'd say within like 3, 4, 5 months. No, after that, dude, I had my patients in the freaking clinic doing deadlifts, man. She was doing deadlifts and practicing form with that.
To be completely honest, I love my fused lumbar clients because they deadlifted perfectly. They were stuck in extension.
Touche.
But anyways, obviously I didn't want them like, hey, don't relax. I don't want you relying on a steel rod.
No, yeah. That's touche.
But anyways, I bring him up specifically because the day after deadlifting, and all this is subjective, right? This is why I never really care about where somebody feels a workout, because it's so subjective. But the next day, and it was good because he had no background in lifting weights, so he didn't know what the right thing to say was. So he just told me the honest truth, which is the best. And the thing that came to mind, he's like, Aaron, after those deadlifts, my obliques, the side, he didn't say obliques, but he's like, my sides, like they are so sore right now. And it's like, imagine that.
Exactly.
And again, I was so happy that he wasn't engulfed in the cliches. So, because I almost wonder, had he been like, would he have said like, oh, my low back or something? Just side anecdote there. But it was just awesome to see like how like powerful his response in the abdominal region for him per se with the deadlift was. And again, not saying that the deadlift was like extra sensitive to his obliques. All that told me was like his obliques were really weak in comparison to everything else, so but yeah, it was just there's the bracing aspect is extremely critical to me because of its performance implementations, right? I'm more concerned with form for the sake of high output, high performance than anything else. I want you moving well because it's efficient, right? That's my scope of practice. I'm focused on efficiency, and so that's my positive note for core stabilization.
I think for me, man, again, if anybody has any questions to this or anything that you'd like either one of us to answer down in the comments, just put something, and we both may come with completely different perspectives, but honestly, that's okay. From a just fitness and health and wellness standpoint, we wouldn't get anywhere if we didn't challenge each other, if we didn't disagree, and go from there. I think if we just rely on literature, I think we're kind of lacking as well. We both have experiences over the past 10 years that have helped shape our opinion as well. So I think it'd be interesting to see someone who's on way over here from yes, everybody needs core stabilization, and then you're not way over here because I think you're like, well, I understand it needs it sometimes, or I understand some portion of it, but I don't know. It'd be interesting. I'd love to hear it.
Yeah.
Great. So I actually got a buddy that, and he's not way over there, but I think he has a better understanding than I do, even with that and its implementation, having worked on motor control and movement science and things like that for several years now. He's a little bit more entrenched in that. I'd love to get him on maybe one day and we'll all three get on a call and just ask some questions and just go back and forth. But overall, guys, if you guys have questions, I think it'd be awesome. Just put it down in the comment section, again, just leave it in the comment section and we'll get back to it. And you may get some different viewpoints, but I think that's good. So
Awesome.
Perfect.
Well, like I said, next time we're gonna have to find something we disagree more on.
Well, I think
It always comes down to this is how it'll be. We think we disagree, and
well, I think to some degree though, I'm like, okay, that fused patient, or some people do need it, and I will
yeah,
stick by that. That as long as they fit within, I don't always just throw them into, lifting. Do I like to get them there? Absolutely. So I think there's some disagreement in the sense that you're like, well, it'll work whenever it's going to work how it's going to. And I'm like, I want to kind of train it to do that first. So we can agree to disagree on that. That's all right.
sure,
We'll be
sure.
okay.
We'll have to find some juicier content to really get at each other.
But you know what? I think the reality is,